I saw in one of your slides there was a bullet about, I think it was on naloxone, and your fourth comment about withdrawal. And I've seen one other presentation on rural opioid problems. Is there an instant withdrawal when you reverse this agent? I was told to be aware of them possibly being combative because you've taken away their high, but can you tell me a little bit more about the withdrawal scenario?
Yes, they can, because it's basically what it's doing is the opioid binds to a receptor on the brain. The naloxone will push that off. It's got a stronger affinity, so it's going to push the opioid off, and so it's basically, since that's gone, it's putting them into withdrawal. And they say, the person can be combative. I've heard, some of them say, of course, that's probably more when they were using the heroin. You've messed up my high, and upset about it. It's like, but we kind of saved your life. So, yes, they can experience the withdrawal from that. So.
All right. Next question is sort of related to that too, but not specific to anyone on the panel. So I've sort of been doing, I'm an RN and been working sort of in the desk setting for the past 10 years, but I also teach CPR. And I'm saying within the past 2 years, they've sort of integrated the naloxone piece, and they didn't give us a whole lot of instruction with that. So I've been kind of, saying this is what I think and giving my rationales. But they said there's a part in the video now that's released that says you might find yourself in a situation where you may need to administer this, but they don't give us a lot of guidance on who, what, where, and when, and why. So if some of you could say, when would this be a situation where you would be, because there was mention of a prescription and it's not required, because I started out as saying that you're not going to see this scenario. They shouldn't have added to the video. Personally, this is what I was saying. I thought they had got too far ahead because I didn't know anything about this until I actually saw the video. So when will we actually, as healthcare providers, be exposed to a situation where we would be in a situation where we would administer it versus, because from my instruction, we're talking about providing CPR, retrieving an AED, and this would be readily accessible. And my experience, and part of the reason why I had mentioned being a desk job was I thought this was a controlled substance, and now it seems like it isn't anymore.
Well, no, naloxone's not a controlled substance. Honestly, that's a good question, and I just did my CPR training last week, but refresher. But it's hard to say, because that's, as you were talking about that, I was thinking in my own mind, because usually when you witness somebody, and they're, if you don't have any knowledge of the person, you wouldn't necessarily know if they were using anything that could potentially cause that. So I would say maybe some of the signs that we train on, do they have, bluish, gray ashen skin, discoloration of the lips, the nails? Are they still having some very shallow breathing to where maybe you think it might be something other than a heart attack? Is that, am I going in the right direction with what you're meaning? Is if you have a naloxone yourself to be able to administer to somebody? Well,
I personally, and most people wouldn't, but they said you might find yourself in a situation where you would, as part of your first aid or CPR scenario, you would administer it. But when are we actually going to be exposed to that? Because most people don't have it.
Right. Okay.
I can answer that. So if you find someone down in a restaurant and you think they may have overdosed, a lot of times you'll search their person and they may actually have Narcan on their possession. They may have it in their purse. They may have it in their pants pocket, that sort of thing. First responders are now carrying it, so most law enforcement will have it. Now, they would be the ones to administer it once they show up, but a lot of times the individual or their friends will have it on them. And so that would be the scenario that you might find yourself administering it.
And there also is the Good Samaritan law too, where you cannot be held.
I think there's a question right there.
What specific recommendations can you give to prescribers to follow a good way to do this. I mean, when I prescribe a narcotic, I try to use always PRN, not a schedule. First thing, I try to use the mild narcotic, tramadol, codeine are first options for me always. Of course, I need to look for contraindications and things like that. I add lidocaine patches, capsaicin, those kind of things, physical therapy, cognitive behavioral therapy, and all those kind of things. What other recommendations do you think is a good idea to do in prescribing a narcotic for chronic pain?
I think you're doing great if you're doing all those things. That's wonderful. Do you guys have anything that?
Well, I think going back to what Dr. Abbott had said is having those scheduled ones, so we don't use the PRN as often, and then integrating those into the scheduled doses that they're getting for chronic pain would be probably a little safer.
The reason why I like to use PRN is because sometimes the patient does not measure pain properly, So if I put every 4 hours, he's going to take it every 4 hours sometimes. So that's why I like to do always PRN and not a schedule. And that's why when I do the random screen, I need to ask, how often are you taking the medication? Because they can tell me, oh, you told me to take a PRN. However, they're coming to pick up the prescription every 30 days.
Right.
Like they're taking the medication, not PRN.
Yeah, I mean, I think just like with anxiety, for example, we give them alprazolam or clonazepam, things like that as PRNs. We still have to have another agent that will bring that down in the long run to decrease the use of those. Same thing with this. I mean, correct me if I'm wrong, but Dr. Abbott kind of spoke about making sure their schedule is enough that it's covering throughout the day. So they're going to eventually decrease the use of those PRNs. And if they are, you add that into the scheduled dose so you get longer effect for that. I don't know if anyone had another thought on that.
I think also if it's appropriate, using one of the adjuvants like the, if it's a neuropathic pain, then are we using the appropriate medication? So I think that would be something else to think about. Or, could they use an NSAID? Are they appropriate for that versus the...
How often do you use Celebrex, for example? I like to, not to, some patients are, very old and you're scared about creating an ulcer and GI bleed and those kind of things. So I try to use Celebrex, the lowest dose possible too. And do you use that frequently? Or?
And you could also consider, if you're worried if they're more at risk for GI symptoms, then you could add on an H2 blocker or a PPI. That would be another option. And I always like to say, just because they've tried one NSAID doesn't mean, and it wasn't effective, try several. I think it can be very patient specific. Just like I tell people, my example is my own personal. I don't like naproxen for me. It doesn't do much good for me. I like ibuprofen. Somebody else is the exact opposite. So it's just, and there's so many out there. You've got a Totolac and the meloxicam, diclofenac, and there's a lot of them out there. So definitely if they're a candidate for it, especially if they're younger, we don't need to get some of these younger people started on an opioid that we're trying the options whenever it's a good, safe alternative. And as well as the diclofenac gel, if it's, somebody that's their pain is appropriate for that. It's not like they can rub it all over their body or anything, but if they've got something that's amenable to that, then that's another good option too, for if an oral NSAID is not a good option.
I have a general question. What about the forgotten generations, the nursing home patients? If you've ever worked in a nursing home, everybody has Norco, everybody has fentanyl patches. Are these guys getting trained on Narcan also, their nurses? Because some of those side effects you see every day in the elderly.
Right.
How can you tell the difference between that and an overdose?
That's a good question. I mean, I don't know if they are being.
Yeah, I don't know the
trained or
level
not.
of training that
Yeah.
and availability of Narcan in
Right.
nursing homes. I just don't know.
I was wanting to ask, all right, I know we're trying to help our people that are struggling with addiction, but what resources are out there for parents that have a child or a grown adult child that are messed up in this mess that we've got going on in our country right now. What about as parents or family members or friends that are on the sidelines drowning, trying to figure out where in the hell did I go wrong? How can I help? Because there's a lot of us out there that need help. What kind of resource do you have available? What can parents or family members reach out to? Because we don't know what to do.
I know there are various support groups, like for alcoholics specifically. There's like Al-Anon, which is parents of individuals who've had alcoholics in their family, but not sure about that. I know there's the SAMHSA website, which has some good resources.
Some chapters of NAMI, so the National Alliance for Mentally Ill, nationally, they're really focused on depression, schizophrenia, bipolar, anxiety disorders. But some chapters of NAMI have actually become very proactive in especially opioids. And NAMI is really geared towards family members. It's not geared towards the individual who has the illness. It's geared towards the family members and teaching them how they can support and help get resources and find support from other families in the community who are also experiencing the same struggles. So I don't know if your local NAMI has that as part of their mission or not, but that'd be an option too.
And I would say that if your loved one, family member, friend, whatever, if it is a opioid related thing that they are abusing, have a naloxone for yourself and keep that with you. So that way, if you come across them, then, don't rely on them to have it, even if they've been prescribed one, because, Lord only knows where it might be. But if you carry one in your purse, then at least, if you go to check on them and they're down, then you've got it.
And you can get that without a prescription.
Yeah, you can get that without a prescription at a pharmacy. Mm-hmm.
And one of the things I'd like to add about that as well is giving Narcan to somebody who overdosed on something else or isn't having an overdose won't harm them.
Right.
So that's something to remember. But if they overdose on something like a benzodiazepine, it won't reverse that. But knowing that it won't cause them harm is still beneficial, so you can still try it if that's what you're concerned about.
And I would say if you're in the Southern Illinois region, I'm not sure where you're from, but contact coalition groups down there, because there are parents and people in recovery that are members of the coalitions, and we organize we have an event tomorrow night in Whittington, which is in Franklin County, and it's sort of co-organized with Celebrate Recovery that's housed at Whittington Church in Franklin County. So there's often a lot of family members of people who are experiencing opioid use disorder, SUD, people in recovery, and along with the larger community. So we're trying to bring everyone together with these community type events in Southern Illinois. I'm not sure about in this county, but.
I was just curious about how other people practice for outpatient rural clinics. With our clinic, we usually do annual controlled substance contracts and the random urine drug screens. But our administration has decided to not collect the urine in clinic, as there's no chain of custody or chain of command, and so the courier would have to take the urine specimen to an outpatient lab. So we end up giving them an order for them to go to an outpatient lab or go over to the hospital, and then it becomes not so random. Sometimes they don't get it 3 months later, 6 months later. Anybody has a different practice?
I would say that you could make it contingent upon, renewal of the medication, as far as if they are, you tell them to go and you give them a reasonable amount of time, and then, the next time they call for renewal, say, I'm sorry, but you haven't done your urine drug screen, and so we can't safely, we're doing this for your safety. There are things that you can do besides the urine drug screen, as far as if you think that it could be an adulterated sample, then checking a normal urinalysis that's got the specific gravity, and they can check the urine creatinine, and there's variations in that could tell you I'm not sure if it's something that's sat around for a little while, but if it's something that they go to the lab and get right there, then you should be able to, if you order that in addition.
And the best practice really is that you do it in your own clinic. And chain of custody, I imagine, is not really what they're concerned about, because chain of custody really has to do with legal, and you're not going to prosecute somebody in this scenario. But they may have concerns about being able to keep it at the right temperature so that it doesn't grow microorganisms that would look like a UTI and that sort of thing. But some places that don't have the ability to do the lab in their own setting have set up, especially pain clinics have done this, have set up that we will call you, and within 12 hours of you getting that call, you have to go into the lab and get your urine tested. So that brings back the element of random versus we're going to give you this order and at your convenience, go do it before we will refill your prescription in 3 months or whatever. So that brings in the element of random again.
This is a comment, I'm guilty about this because when I have a patient with an addiction with narcotics and I find out about it, what everybody tends to do is fire the patient, and we need to realize this patient has an addiction and needs help. And we should, instead of fire the patient, saying to the patient, I can help you out with this addiction. It's your decision if you want to continue with me or not. If I can help you out. But I see that not a lot of physicians do that. The easy way is just to say, you're done with me. You're going to find another primary care physician, and we're not fixing anything. We put in the problem in another person.
Mm-hmm. And it's something too that I forgot to mention whenever I talked about, and that was at the end of my talk, but about tapering off. Whenever you do have somebody that's agreeable to it and said, yeah, okay, maybe I really don't need to be on this, it's the possibility that you could uncover an opioid use disorder as you're tapering somebody off of the medication. They may not realize they have that because they've just been getting what they needed. And so they didn't necessarily exhibit the behaviors of med seeking, but they may realize at that point, I might need to do something different. So that's something to be aware of as you're tapering, that you might need to be able to coordinate services for them.
And it may, if you don't have any mental health professionals available in your clinic, it may behoove you to reach out to the mental health center in your county and just talk with them about how you can get some of the mental health resources as you are tapering people off and uncovering an opioid use disorder.
So my question is just related to like where the resources are located. We talk about, finding these resources. I mean, I would just like to see from each of the counties, here are all the MAT programs, here are all the phone numbers, here are the places, because even me being in inpatient setting, I can't tell you right now what that list is and what the numbers are off the top of my head. So I think that would be very helpful for coalitions and other things to every county. Here's the list of all the phone numbers and the resources and the providers that can prescribe, so that everyone knows who they can call to get that assistance.
So I believe the SAMHSA website does that really well. And most of the mental health centers can usually be contacted. So here it'd be the Mental Health Center of Central Illinois or Southern Illinois, depending on where you are. But the SAMHSA website definitely has a lot of those resources.
And the Healthy Southern Illinois Delta Network, I showed that slide, hsidn.org for the lower 15 counties. There's a substance abuse resource guide that's on there. There's a whole list of resources on that website for at least the southern counties. So, I mean, we have that for down there, but.
And for Sangamon County, I work at the Public Health Department. They have a community resource guide that has everything from clothing assistance, medication assistance, mental health, substance abuse. Yeah, so contact the Community Resource Center. And then I had a question. When you guys were doing your research for your presentations, was there any research or statistics out there about what age they're more prevalent on becoming addicted? Because you could have a teenager with a sports injury that has ACL repair and they're on some narcotics post-surgery, or are we talking more older adults? Is there any breakdown in age that you guys came across? Like who's more at risk?
I mean, I've seen studies where adolescents and younger adults that are using marijuana, it can lead to opioid use disorder and heroin. But I don't know about specific age groups. I know it's prevalent in all age groups, but I'm not sure if there's a higher population.
Yeah, so the studies haven't actually borne out that there's a certain population that's most at risk. From kind of the theoretical construct, we think that the developing brain is the most vulnerable. So adolescents, young adults, because your brain really develops until about 30. So that's where we kind of think it's most. But when you look at the statistics in terms of prevalence rates, it's across all age spans.
That I wanted to comment on whenever we were talking about the heroin and the fentanyl and carfentanil. I don't know if people have heard of kratom. It can act like an opioid in the body, and there's places that say it's illegal, it's a plant, it's safe. There's addiction treatment facilities for kratom, so it's, if your patients ask you about it, it's probably not the best option.
And kratom doesn't show up on urine drug toxicology, right?
I don't think so. Or if it does, it shows up as an opioid. Yeah, I'm not sure.
Well, many of the things that people take don't show up on your urine drug screens. So K2 spice seldom shows up, and the people who are manufacturing K2 are frequently changing the ingredients as the drug tests will become sensitive to one version of it. They change the ingredients.
Will Narcan help reverse the effects of K2?
No.
Not at all? Okay.
Well, so you have to understand K2, and we don't have a lot of K2 here. I was in Austin before I came here, and we had a ton of K2. K2 is a synthetic marijuana that can have anything in it. So sometimes the person who's manufacturing it will cut it with some heroin or cut it with something else. So it can have an opioid in it. And so in that scenario, yes, the opioid that would be in the K2 would respond to Narcan. But the synthetic marijuana itself, no.
So I realize this is an opioid conference, but what about the benzos and the stimulant medications and overdoses on all that? Is that not as significant as the opioids?
No, it definitely is. And they've shown that the overdose risk and rates have skyrocketed with a combination of especially benzodiazepines and opioids. As we know, that combination causes a respiratory suppression. And there have been a lot of fatal overdoses, and there have been more ER-related visits with benzodiazepines and opioids. Stimulants, I haven't seen much data on overdoses. Mm-hmm.
Yeah, so both the benzos and the opioids are going to cause respiratory depression, which is what you really worry about with the overdose. Stimulants don't.
By itself, it's less likely to cause issues. Benzo by itself is less likely to cause.
Correct.
Yeah, it's usually mixed with something else.
Alcohol or opioid.
Another thing I wanted to add, Imodium has been increasingly used by a lot of people who are addicted to opioids, so that's something to keep in mind. They act kind of similarly. Maybe you can explain that a little bit more, the receptors, but people have been using that quite frequently as well. So
Dextromethorphan.
Mm-hmm.
And I think the pharmacies now, at least I know the pharmacy, that chain that I still do relief work at, there is a hard stop on the register that they have to be at least 18 to buy the dextromethorphan containing products. They will drink a whole bottle of it yeah. Nasty, but yeah.
I had a question about the Ethic project. Mm-hmm. So I know the focus was on HIV, hepatitis C, and sexually transmitted infections, but I was wondering, is there any data available on different skin infections like cellulitis, necrotizing fasciitis? Because I see a lot of these IV drug users that have skin infections. I was just wondering if you came across that.
I haven't seen any, and we haven't discussed it with regards to that project.
Okay.
But that's definitely something to look into.
Okay, where was the data pulled from? I was just curious.
For Ethic, I mean, it's just starting right now.
Okay.
So they're recruiting injection drug users to do the surveys and the tests as, right now.
Great.
It's a 4-year project though, so the first 2 years will be the surveys with injection drug users and opioid users, as well as surveys with community stakeholders. And then the second 2 years will be, looking at that data and designing interventions, like targeted interventions in the Delta region. So we need those down there.
All right, well, thank you.